Welcome everyone to the RISE webinar on population health management. We appreciate you spending the time with us today. As we know, it's a very busy time for everyone. We'll start in a few minutes once people have had a chance to sign on. My name is Leslie McGeough and I will be your host for today's webinar. I'm a focal point with RISE and I work for Trillium Health Partners. Today's webinar is about population health management, a core concept for Ontario health teams. We used your feedback to develop today's session and heard how many of you are working on your care models. So today we will focus on co-designing care models for your priority populations. We also heard from you that you want to continue developing connections and sharing ideas with other OHTs and experts. So as you join today's webinar, please introduce yourself, your organization, or OHT. You can do this by selecting the chat box in the right-hand portion of your screen and selecting everyone from the drop-down. My colleague at RISE, Stephen Lott, is also supporting us behind the scenes to ensure that everything runs smoothly. If you have issues with WebEx, you can message the host and he can help you resolve them. Just take a quick look at the chat box and see who's joining us today. Welcome, Melissa from Chatham-Kent OHT. Thank you for joining us. We also have the RISE Population Health Management coaches here today. Hello to the coaches. Welcome, Lisa from Northumberland. Welcome, Kelly from the Provincial Geriatrics Leadership of Ontario. Thank you for joining today. Hello, Nancy from Western OHT. Hi, Anna from Near North Health and Wellness. Thanks for joining. And Mark from Oxford. Oh my goodness, they're coming in so quickly, I can't keep up. Megan, welcome. Stephanie. We also have Dr. Carrie Koleski here with us today, who will share some key considerations and tools for including the patient experience when co-designing care models. So welcome to Dr. Koleski. Welcome, Sarah from South Georgian. Hello from CEP. Hi, Pippi. Nice to see you. Please also feel free to share your Twitter handle or email so you can continue your conversations beyond today. We will also share a summary with you, including the emails and Twitter handles you share in the chat box following today's session. Ours is posted on the slides, so you can follow us and stay up to date on RISE events and resources. Following today's session, we'll also share a recording of our webinar, the deck, and a one-page summary. Welcome, Tara from Ontario Palliative Care Network, and Abigail and Chloe from the Burlington OHT, patients and partner. All right, we're a few minutes in now, so we'll begin the session, but please continue to introduce yourselves in the chat box and feel free to add your questions there as we'll have a discussion period later on. Thank you all for joining us. So before we start today's session, we'd like to recognize the land on which we work. As we meet here today, we are in solidarity with Indigenous peoples of Turtle Island and would like to begin by acknowledging that the land on which we gather is part of the treaty lands and the territory of the Mississaugas of the Credit, and before the traditional territory of the Haudenosaunee, Huron, and Wendat. We also acknowledge the many First Nations, Inuit, Métis, and other global Indigenous peoples who now call this area their home. We are grateful for the opportunity to be working on this land. Before we dive into today's learning, we would like to do a quick poll. Please reference the right-hand side of your screen and click on the drop down for polling. We'll give you about a minute to complete this poll. We'd like to know if you were able to join our RISE Population Health Management webinar in January. This webinar in January provided an overview of core concepts and focused on population segmentation. We'll give you a few more seconds to put in your answers. We'll also post in the chat box last month's webinar along with a one-page summary. So for those of you who could not join, you can check it out online. Okay, Steve, are we ready to share the results? Can't see them come up just yet. Okay, so we have, not everyone got a chance to answer, sorry, I'll give you more time next time. Looks like that we have lots of new people joining us today, so it's great to have you here. And for those of you who came in January, we're happy to have you back. We hope we can continue to have you coming back and welcome your feedback following these sessions so that we can continue to make these sessions of the most value to you. I'm now going to introduce Dr. Rob Reed, our RISE co-lead. He's going to provide an introduction to our webinar today and to co-designing care models.
Thank you, Leslie, and I hope everybody can hear me today. It's great to be back. I see some familiar names and I see some new people. So it's terrific that you're all joining us today. You know, this is, and I do want to call out, I know how incredibly busy it is right now across our sector with all of the things going on around COVID and the recovery from it. I know how busy everybody is. And I'm very grateful that you're prioritizing this to come and spend some time with us today, and that you have a commitment around working with your population over time with the OHT. That's just terrific. Today's meeting is really around the second step in our population health trajectory around care model redesign. And it follows on the last session that we had on getting to know your population, understanding it, being able to segment, and looking at your priority population with a variety of data, that then you can actually move on to the next phase, which is the care model design for those segments. So it's terrifically exciting to be with you on to this next step. And today the purpose is really to share some approaches that around co-designing care models for your segmented populations. And we have some experts here that will help us through this. Understand some of the key changes that you'll need to improve the outcomes for your priority populations. And then again, our overall objective is to cultivate shared learnings by hearing from your peer OHTs around their population health management trajectory. Today, in addition to Leslie and Steve, we have Mike Hindmarsh, which Mike has joined me before on the webinar. So welcome back, Mike. And Mike is actually going to take a big leadership role on this webinar. So I'm going to hand it over to him in a minute. We also have Christina, who is one of our population health management coaches, and she's going to talk through a particular care model that many of you are thinking about. And then finally, we've had a lot of questions about patient-centeredness, and we've invited Carrie Kalusky. Dr. Kalusky is joining us today. She is a real provincial expert on how you involve patients in OHTs, engage them, and work with them around co-design. This is just a bit of a teaser, and we're hoping at some point to invite Dr. Kalusky back to talk more about this subject. Okay, let's move on to the next slide, Steve. Okay, this is a slide that we used last time, and it's just to remind everybody that this is a long-term journey around population health management, and we're doing it in the middle of COVID times. And I know many of you are taking your population perspectives now, the management techniques, and actually applying it to the COVID, both the management of COVID and soon the recovery of COVID. And that's just, in my view, terrific. Today, we're talking about care model redesign. We're going to be talking in future sessions about working with communities, public organizations, and how to adjust your learnings over time. As to, you know, and then the eventual is to expand it across your entire attributed populations in addition to your priority population right now. And if you remember the webinar, I think many of you were on the webinar that Dr. Walter Watchis gave a few last month, where he showed a variety of real model population management places in the world who are doing this very well. And one of the critical learning is that this is a journey over time, that many of those places took many years to develop their capabilities. And so we are on a journey here. Okay. Let's Let's move to the next slide. You probably remember this slide. We keep repeating this slide over and over again. These are the 4 steps in really clinical population health management, that second curve that I've talked about several times now. And really last time we talked about issues around segmentation, how to understand needs, how to understand risks, and the importance of understanding barriers to be able to find patients who have similar needs in your populations that then you can design care models for that are longitudinal. So today is all about co-designing care models and a service mix to meet those population-based segments. We'll be going on to the other steps in this population health management journey in the next webinars. And just remember that, you know, although we've said that there's steps 1, 2, 3, and 4, that many of you are working on all of these simultaneously, and that's fine. We're developing these capabilities over time for everybody. Okay. And since the last webinar, our coaches have now been out talking to many of you. And I'm just so terrifically excited that they've had real conversations now about your particular issues around population health management. And we've asked our coaches what they've learned from you. And these are some general things that they've learned so far. And I wanted to put them up here because these are the types of things that we'll be addressing here. First of all, many of you are saying that we actually already have care models out there and we don't want to reinvent the wheel. We just want to adapt what we're currently using. And that makes a whole bunch of sense. And we'll be talking about that. Many of you have really talked and honed in on the equity issues and how you make sure you attend to equity considerations as you design care models. So we'll talk a little bit about that today, and we'll have more on that in the future. Many of you, if not most of you, are wanting more information around how to engage patients, families, and caregivers in the co-design activities. And Dr. Koleski is going to talk a little bit about that today. And then finally, how can we tailor care models to look at our own realities? All of our OHTs are different in terms of what their resources are, their partners are, their foci are, and so clearly we need to adapt them for local circumstances. And then finally, there's a lot of movement at the provincial level here, and it is really balancing provincial level, provincial initiatives in local context. So those were the main questions that we've heard. As you're meeting with your coaches now in the next month or so, make sure you surface more issues that you want us to talk about, and we'll keep coming back to them because these are the critical issues that we're all learning around together. Okay. Okay, so before I start, before we started really launching into this topic, I wanted you to do a new poll for us and just quickly say to us, sorry, I can't read it here. Please rate your level of familiarity with co-design, how we co-design care models for populations of patients. Being a low level of familiarity, and that's perfectly fine. That's what we're here to talk about. And then 5, being very, very familiar, and I know many of you are well on your way. So take a minute and just respond to that, and then Leslie, you can tell me the results, okay?
I think Steve has control on the polls, so I think Steve, once you see that we've hit close to most of the participants, maybe we can end it. And just for everyone who is participating in the poll, so we use this to help create our future collaboratives and webinar discussions. So we really value your feedback to ensure we're creating something that's of value to you. So this will be helpful for us as we customize the learning program going forward. All right, Steve, did you want to end the poll? And I think we'll just wait a minute for the results to display. I'm not able to see them yet, so Rob, if you're able to see them, or
no,
Steve,
I can't.
Feel free to comment.
I can't either. Oh, here we are. Let's see. Okay, we have people across the spectrum here. So some people that this is a real introduction to them, and then some people that are real experts. So there's a real heterogeneity here, which is just terrific, Leslie, and that gives us opportunity to learn from each other. Let's move to the next slide. Okay, one thing as I start here, I just wanted to really clarify some issues that we've heard in the field right now. Many people are saying, well, we have a care model because we actually are developing a care pathway. And we really wanted to start off this with just clarifying the difference between what we talk about as a care model versus a care pathway. A care pathway is an essential element to a care model. It tells us the route that patients in a particular segment in an idealized way will move over time between different parts of our OHT and between different service units and providers, and what the clinical interventions will be. So it's a bit of a roadmap for patients as they're moving through the OHT, an essential component. When we talk about care models, it really is now inserting those care pathways in actually a model of care. So we actually know how to get people through the care pathways, not just what the care pathway is. So the way that I think about this is if we think about a car, I think about the GPS as a care pathway. It tells me the route of where I'm going to go. And it's absolutely essential that I know where I'm going to go to get back to the store and back home again. The care model is actually the engine of the car. It will take us there and bring us back. And that's what we're talking about in care models. So I just wanted to emphasize that point to start with. And now I'm done. So I'm going to hand it over to Mike, who's going to go through the rest of the presentation, and then I'll pick us up back at the end.
Welcome, everyone. I'm glad to see everyone that could make it. And let me echo what Rob said. It's great that you were able to make this, especially given what a busy time it is. What I want to talk to you about briefly is what does co-design really look like? For some of you that have been through this, this will be remedial, but I think it's important to recognize that there's a lot of moving parts to this. So many of you, the coaches have talked to many of you, and you're working with your initial population segments inside your priority populations. And as Rob said, we unfortunately can't start and build a whole new car. We have to take the existing car and repair it and fix the gaps in the care system that we have. So there are basically three scenarios that you're going to be facing at any given time. You're going to have to create change inside the new type of system. Maybe it's a new care pathway or a new visit structure, whatever it might be. Scenario two is where you found a gap in care, but you can fill that gap with the existing system structures if they're just redeployed slightly differently. And then the third scenario of change is really redesigning existing systems, which is where I think a lot of you will be. You have current systems that are in place, but they aren't working properly, or they aren't working optimally in a population health management fashion. They may work well for individuals, but they're not working well across the population. So as you start thinking about what those changes are, you'll be working with your coaches. Many of you have developed logic models already around certain changes you want to do. Your coaches also can help you with driver diagrams if you find those easier to work with. And your action teams and work groups are now starting to do some of that work. They're having to develop interim measures around the particular change that they're doing so that they can see if the changes they make as they're testing those changes are resulting in improvement. Those are different from the global measures that you would be seeing from the Ministry of Health, let's say. These are project-specific measures that your coaches will help you with. You want to make sure that you test these changes so that there are no failures when you move to that third step in Rob's diagram of implementation. So this testing is absolutely critical. We don't want to rush to implementation because certainly if you rush to implementation on a system-wide level and things fail, then clearly that's pretty disruptive. The next piece you're going to do is when you're ready for implementation, you're going to be sitting down and saying, okay, how do we now test to see, can we go system-wide with this particular change? We know that there were no failures during, we fixed all the failures during testing. We're ready for prime time, but you will need to sit down and say, what does it mean to go, let's say, from one primary care practice to 300 and what's involved in that. So the same kind of co-design work is going to be just as important at implementation. And then clearly, once you've implemented and things are running well, you've got to make sure that you have a process for monitoring the system that you've put in place and evaluating it and doing continuous quality improvement based either on research evidence, best practice, or whatever might require that you make a change with it. As I said, at the bottom here, at the top, so you're beginning with the segmented population that you're working with, but you also have to keep in mind that you're going to be working with your whole priority population over time. So as you're designing changes for your particular segment, you have to keep in mind that you might have other segments you've got to start doing design work for also. You'll see a good example of that when Christina talks about the frailty care model that some of you are using. Let's go to the next slide. So when we talk about co-design, there are some overarching change concepts that we have to think about. When I say a change concept, these are good ideas that are useful to help rebuild systems or redesign systems that are either evidence-based or based in best practice, and at the least, expert recommended changes. And they fall into those general categories that you see on the side there: delivery system redesign, clinical decision-making, information technology, self-management support for patients, and community resources. I'm going to talk briefly about each one, but it's important as I go through these, I'll be going through fairly quickly. It's important for you to know your coaches are very familiar with all of these change concepts and can help you with them. So if you come away from the presentation and you have more questions and answers, your coaches can certainly help you with those. Let's take a look at delivery system redesign. A lot of this will be very familiar to you. The kind of questions you want to think about are what part of the system needs redesigning, what systems do I have to develop? Those are the kind of scenarios I talked about earlier. And clearly, coordination of care is at the center of a lot of the OHT work. We need to make sure that we have effective care transitions no matter where they're happening, that there are stepped care protocols when appropriate, integrated case management functionality, and that's making sure that any case management going on with patients is known across the system, since the patient is likely to touch the system in a variety of places. System navigation, we all know that patients have a lot of trouble going through the system. Regular assessment of disease severity, so you can monitor how the patients are doing with their care, and certainly medication reconciliation is a big issue. So systems to make sure all of those things happen. You want to proactively do in-reach and outreach, have that kind of functionality across the system. So you want to make sure that you can find patients when you need to find them, and you also want to outreach to patients. A patient being discharged from the ED is an opportunity to do proactive care and reach out to that patient and see what their care needs are. So that kind of functionality needs to be built into the OHT. And clearly you want to have an emphasis on equity across the system and access. We have a lot of access blockage throughout the system in various points. You want to have planned care versus reactive care, and I think most of you understand this one intuitively. We don't want to wait for patients to show up at somewhere in the system in crisis or with an acute exacerbation of their situation. We want to actually plan their care so that we can make sure that we deliver the clinical care and also self-management support, which I'll mention in a minute. Make sure that we deliver those to patients so that they stay in good control and avoid those acute exacerbations. Recall functionality. Somewhere in the system, whoever is coordinating care for the patient, and what I've seen from most of you is that you're looking at primary care as being the central coordinator. We want to be able to recall patients when we need to have them come in. Rather than waiting for them to come in for their regular follow-up, we proactively bring them in and make sure that those visits are tailored to not only what the patient needs in the moment, but also to deliver the clinical care that's needed. And then clearly, all of this care has to be culturally sensitive to patients, no matter where they touch the system. And again, as you'll see in the triangle in the bottom, all redesign needs to be informed by socioeconomic factors. Let's take a look at the next component, When we talk about clinical decision supports, we want to make sure the evidence-based guidelines are embedded in care. You know what the care is, and if you aren't sure, you can find it very quickly. Specialty care and primary care, home care, all of them have agreements on how they handle those patients and how they handle referrals. Communication needs to go both ways. Many patients get lost when they go into one of those parts of the system, and the others have, and typically primary care has very little information about what has actually transpired with the patient. Or the feedback is so varied across different specialists or across different home care situations that the primary care provider has to try and figure out each recommendation that they get. Same thing with clinical case management. If you've decided that a patient that is at rising risk for disease, increased disease or frailty or becoming homebound, you want to make sure that clinical case management agreements are similar across the organization so that they make sense to everyone wherever the patient touches the system. Obviously, we have to consider social factors. We have to consider the fact that a lot of people are just having trouble making ends meet, let alone taking care of themselves. So certainly for marginalized populations and populations that are racialized, we have to take in those social factors, but also across the whole population. Who's living in poverty? Who's having trouble with food? Who can't afford their medications? These social factors are often the biggest barrier to patients taking good care of themselves and barriers to clinical case or barriers to clinical care. Everyone in the circle of care across OHT must understand what the care model is so that they know when a patient shows up at any given point, what is their role in that care model and what things do they do with the patient as well as who do they follow up with in the system. And in the same way, patients and caregivers need to be educated about the model of care. I've always maintained that if my reward for turning 50 is a colonoscopy, someone better explain that process to me because I'm unlikely to show up for it. Let's go to the next one. Next slide, sorry. Information technology. We've been saying this message continually for the last couple of months. You've got to look at your priority population and segment them into the groups that you need to do certain things for, whatever that might be. So you want to be able to pull out those segments from your priority population. You can do it through registries or a variety of ways, but registries are a fairly simple way to do it. You want to facilitate individual patient care planning across the OHT partners. So over the years, we've talked about how does the patient's care plan or treatment plan make it to the hospital or make it to specialty care or make it to home care from primary care. Those are the pieces that we've got to figure out. How do we make sure that that patient treatment plan either travels with the patient or somewhere inside our system that anyone at any caregiver or provider of care that sees the patient can pull up their treatment plan. You want to provide reminders for providers and patients about care. A very quick point, the easiest way to prevent no-shows is remind patients to come in for their visits. Ideally, we'll have patient portals the patient can access their own information and have input into that, system alerts for critical changes in patient status, and then data to monitor the performance of the team as they build this system. Let's go to the next slide. Self-management support. This is probably the toughest change concept for a lot of folks to implement, but is clearly on everyone's radar. 20 years ago when I started this work, the concept self-management support, no one knew what it was. What I find now is everyone knows what it is, but they're trying to figure out how to build their systems to incorporate self-management support at every encounter with the patient. The key is to emphasize the patient's central role in their care. You're not doing care to them, they're participating in their care with you. Use effective self-management strategies like goal setting and action planning, motivational interviewing, and as I said earlier, redesign your care interaction so that someone at any point in the system can deliver patient self-management support. Because when a patient's going through the system, they should have some level of self-management no matter where they touch the system. Someone should be checking in with them. Let's go to the last one. Community resources. So this has been, I've seen a lot of work across the teams and all the coaches have in terms of engaging community resources. How do we co-design effective models of care with community organizations that are providing care to the patients inside the OHT? So how do we make sure that referral processes are similar and easy to do? That you form partnerships with those community organizations to develop those easy referral processes. How does information go back and forth between the two? Again, this is an information system design issue, but in lieu of a system that can translate information back and forth, we've got to make sure that we have some way of communicating between the two, that the patient has gone to a community organization, received this level of support, and that needs to make it back to the most responsible provider so they understand what the patients receive. Okay, I think I did a whirlwind tour of that. As I said before, your coaches are all familiar with these concepts. I think that if you're going to be doing some work in any of these concepts, using driver diagrams is a great way to think about if I want to do better care coordination, let's say between home care and the hospital, laying that out on paper and seeing what it is you have to design, where are the gaps in care, and what can be put in place and tested to see if they fill those gaps. So quick poll question of all those co-design concepts, please check all of the ones that you need help with, that you feel you need help with. And I noticed on the last two polls that about half of you didn't answer. Please make sure you answer, because we really need to know this information. It's important so that we can deliver that support to you. Let's take about a minute and we'll see what the poll results are. I'll cue Steve in a second. Give you about 20 more seconds to fill it out. Okay, Steve, if you could put up the results once you get them. Okay, looks like a pretty even spread. A little bit more for delivery system design and information technology, but fairly even spread across all of them. So I think it's safe to say that we could probably help you with all of them. Thanks for responding to the poll. And again, if by the way, if you're not working with a coach and you want to be working with a coach, reach out to me or Leslie, and we'll make sure we get you connected with a coach. Great, and I think I'm handing it off to my colleague, Christina Clark.
Thanks, Mike. So what I'm gonna do is to share a really brief example, and what I'm hopeful I'll do in sharing this example is to connect the dots between some of the theory that we're sharing today and practice. So how might you move from segmentation to characterizing needs of the population in that chosen segment, to using that information to work with your partners to design, iterate, and then implement care models, pathways, and services that would meet the needs of that population. And I think I have control of the slides. I'm going backwards. Okay, I'm going too far forwards. I'll get it.
I'm controlling them for you, Christina.
Oh, you are. Okay, thank you. All right. So I wanted to start with an example for the older adult population, just as a starting point, because I know quite a few OHTs have selected that as a priority population. So I'm going to share just one brief approach to segmentation to get us going. This is on your screen, the Clinical Frailty Scale, CFS. It's a tool that was developed by Dr. Ken Rockwood and colleagues at Dalhousie University. Initially, it was developed to summarize the results of a comprehensive geriatric screen, but it is now used quite a bit in primary care settings and other clinical settings to screen for frailty and to broadly stratify degrees of fitness and frailty. So if this is new to you, it is appropriate for use in adults that are 65 and older. You'll see it's numbered 1 through 9, where CFS 1 to 3 would represent people that are fit, very fit to managing well. 4 to 6 represents people that are living with very mild frailty to moderate frailty. CFS 7 to 8 represents people living with an increasing severity of frailty, and 9 would be people approaching end of life and not otherwise frail. So I'll just ask you to advance the slide. So I just want to take this then and match it to the Kaiser risk pyramid, which is probably familiar to many of you from past RISE and HSPN webinars. And I know some of you are using this as a guide to segment your population. So what I've done here is just line up the risk pyramid with the clinical frailty scale so that 0 to 3 could represent older adults that are healthy and managing well. 4 to 6 would capture older adults with mild and moderate frailty that are at risk for further decline. And then as we go up the pyramid, 7 to 8 represents more medically complex and high risk groups where there's increasing severity of frailty and a greater need for services and care coordination. These individuals might be in community or they might be in another care setting. And then finally, at the top of the pyramid would be individuals that would likely benefit from palliative care and additional services. So next slide. This is a quick one just to advance the example. What I'm going to do is I'm just going to focus on the very mildly frail and moderately frail population as our chosen segment, and how would we characterize their needs to begin to think about our care model design. So next slide. Okay. Next slide, actually. Perfect. Okay. So when it comes to characterizing the needs of the population, this is where we really needed some information about our population. And I know this is top of mind for many teams right now. This example will not solve the problem of getting the data you need, but hopefully could give you some ideas for framing questions and process around gathering that. Really simply, there is data that we have now. There is data we have, but we don't have organized access to it. And there might be data that we need to start collecting. So my best suggestion would be to get an inventory of these things, work together on your data use and sharing agreements, as I know many of you are already doing. And where there is data, you don't have, specifically with this example, I'm thinking that it's not common that frailty status is routinely applied or consistently documented in the EMR. So for this, when you're thinking about care model design, you might want to think about, well, how will we build systems and processes into our care model that would proactively and in a standardized way find individuals who are in that rising risk group, the clinical frailty scale 4 to 6, and be able to document their frailty status so that we know it and can respond to their needs on an ongoing basis. We also know there's a few ideas of what data we do have and how we might be able to potentially respond to that in terms of informing the magnitude of the population that we're trying to address and build care models for. But my final suggestion just on this slide is that start small and grow. Most primary care settings will have EMRs that have the ability to create a registry or a report. So you could create a report for all individuals 65 and older, all individuals 75 and older. Specific to this example, there is some literature that shows that this came out of Dr. Linda Lee's family practice in Kitchener-Waterloo, that when they screened everyone 75 and older, they found about 7% were in that 4 to 6 clinical frailty scale group. So that's a resource we can share with you. And then start with one provider's panel and learn and scale up. So now we'll go to the next slide. Perfect. And so this slide attempts to give some ideas of the connection between characterizing the needs in the population and how that gives way to our care model design. So for example, in the first box, if we look at primary care data and find patients in our segment don't have frailty status documented, like I mentioned, we'd probably want to think about standard processes for proactively doing case finding and documentation. The second box would refer to specific strategies the team may be using to organize our patient population data, so for our segment, and using quality strategies to identify and diagnose some care quality issues to develop ideas for developing care models that meet those needs. And so I just want to, I made a note of a comment in the chat box. Kelly Kay mentioned that no-shows among older adults living with complexity are also best addressed by taking care to the patient, home-based assessment and interventions. So that's a great concept that when we're thinking about characterizing patient needs, if as we're building our information systems and we're able to look at something like no-show rates, are seniors able to access our care? And we can use tools like a fishbone diagram to diagnose some of the root causes, and from that get ideas for bringing care to the individual and developing concepts like that that can inform our services and care model. The third and the fourth boxes really just continue this process so that we're using some sound collaborative process to design and iterate models, starting on a small scale first and continuing to build our data infrastructure that helps us measure and respond to needs. And then finally, I think I want to go 2 slides back. Perfect. Okay. And this is sort of the summary slide that thinks through, we start with a segment of 4 to 6, the clinical frailties 4 to 6 perhaps, with an eye though to spread to the entire population. So thinking through services and care models that each of those segments might need. Really my key message here is about matching service to the needs of that specific population. And so it's this example, I hope it gives you some ideas for connecting all of those dots. As Rob mentioned, everyone is really a lot of people are moving with all of these aspects all at once. And I think there's great benefit in not reinventing the wheel, starting with where you are and what you have in terms of your assets in the community, and just looking to connect the dots and using your information as best you can, starting small, figuring out where the care quality gaps are, and then trying to fill those gaps with some of the change concepts that Mike was talking about. With that, I will hand it back to Mike.
Great. Thanks, Christina. I've seen a number of questions in there. There's one for you, Christina. Someone asked, how do you combine physical frailty and social frailty? Is there something that they can use to add to the physical frailty scale? Can't hear you.
Sorry, I was on mute. So I think to understand the question, social frailty, are people thinking about that as social determinants of health? Like, can people afford medications? Do they have access to healthy foods? Is that, I'm going to make an assumption that that's kind of what they're thinking. I don't know all the answers, to be honest. I could definitely follow up and look through some of my resources to find out. I know there's a lot of work going on through Health Excellence Canada, which was formerly the Canadian Foundation for Healthcare Improvement and the Canadian Patient Safety Institute, CSP. I think that's right, the acronym. And they have the Advancing Frailty Care in Community Collaborative ongoing with a whole host of resources, which they've allowed us to share. So there might be something there. I will look and I will bring it back. I think, just off the top of my head, the clinical frailty scale is a really nice composite, but you might also want to introduce some concurrent social determinant screening so that you have a good whole picture of the individual.
Thank you. I'm just looking to see if there's other questions down here. Someone said there's something called a SAMI score that measures complexity of patients, which includes physical and social aspects. So that's something we can look into for you also. There was also a question earlier from Carol, and she asked, what is the difference between the co-design model that I talked about and patient-involved quality improvement. There is no difference. We're talking about the same thing. The co-design process, whether it's a QI project around a lean project or access project, all of them need to have the patient involved at some point, because you're creating a system where the patient's going to be at the center of it. And what you need is feedback from the patient of, does it make sense for us to put this particular process in place? Do you understand it? Have you got suggestions for how to better improve it? So the co-design process would be the same as any other QI design process. It's just that you folks are tasked with redesigning a whole new, a very large system.
Mike, I think that gives us a terrific opportunity to introduce Carrie about patient co-design, because I think you're absolutely right. The co-design actually has to include patients, and not just one patient. We have to represent a variety of different patients in a population. And you know, care is just not about the provision of it, it's also about the receipt of care. And so absolutely central to have patients in those co-design activities. So I think maybe it would be a good opportunity to now hand it over to Carrie, who can talk us a little bit about how we actually do this.
Great.
And I think we have a quick poll just before we bring Carrie on. Thanks, Carrie. How familiar is everyone with co-designed care models with patients and caregivers? Again, we've got a scale over here of 1 being low level of familiarity right up to high level of familiarity. And you know, this is not a test. This is really about how we best support you. So please write your answer, or please click the box that most applies to you, or the circle, I guess it is. And we'll give you a few seconds to complete that, and then see what level of support you folks need around involving patients and caregivers in co-designing care models. Okay, Steve, let's see what the results look like. Normally I give a 20-second warning. I want to make sure Carrie gets enough time. Okay, so we sort of have some clustering in the middle. It's a nice bell-shaped curve, but I think it looks like everyone could use some help, and so we'll make sure that after Carrie finishes talking, if you have any follow-up, again, with anything that Carrie talks about, you can follow up with her or with your coach. Carrie, we'll hand it over to you.
Great. Thank you, Mike, and thank you, Christina and Rob. It's so great to be here this afternoon, so welcome, everyone. So co-designing care with providers, patients, and families is something I'm really passionate about, and something I've been working on for a while. And it's a continuous learning process when you're doing this work, as many of you know. But I think one of the core fundamentals of co-design is not just about improving care, it's about strengthening relationships. So there's a huge relational aspect to the co-design process, and you're strengthening relationships between, if you think of your OHT partners, you're strengthening relationships amongst each other as an OHT. Providers across various sectors are strengthening their relationships, and everyone is strengthening their relationships with patients, families, and the broader community. So if you think of co-design as an activity that could help facilitate that interaction where you're coming together, you're setting priorities, but you're also trying to improve care and building that trust over time, that then becomes a mechanism to support your OHT and this continual learning process that you're going to be doing over the years. And so, you know, there's specific types of ways to kind of facilitate those interactions, even within a pandemic. So you're probably thinking, you know, how can you reasonably come together with various stakeholders, including patients and families and communities, to stay on top of the things that they need and learn how they want to approach different issues. And I've used an approach called the World Cafe. So if you think of a cafe, it's a comfortable environment. It's about relationships. It's about having conversation, and it's about learning from each other. And so we've been doing this work both in person, and then during the pandemic, we've switched to a more virtual environment where we still bring providers, families, patients, organizational leaders together to work in small virtual breakout rooms to tackle core questions, to set priorities, but also to build service improvements based on what you're focusing on. So if you think about, you have your priority populations that you set for your OHTs. So you'd ask yourself, what are the big wicked problems that we have within this priority population? And what are our burning questions? And so if you ask an organizational leader or a provider or an administrator, policymaker, patient, or families, you're going to want to know, how are people defining, say within the palliative care population, what are the biggest struggles that people are having from these different perspectives? And what are their burning questions that they have? So I was thinking back to Kelly's example when she talked about, when people transition, when they're back in the communities and they still need that connection with their care team. That could be a topic that you dig into during a co-design session, where you pull in the perspectives from all of these different stakeholders who can weigh in on the ways in which you can improve that transition and improve that communication with the care team. So that's just one example of how you can continue to facilitate these types of connections. Next slide. And so we know that if we're, using the data we have access to, we only have certain types of data. So we obviously want to know about the physical characteristics of people and their disease characteristics, but what about the social determinants of health? We started to talk about that. What about the social care needs? What about social frailty? So if you're thinking of how to segment your population, you could use existing data to create almost subgroups of individuals, but you might be missing the social factors that characterize those groups. So a really effective way to kind of ground your conversation is to design case vignettes. And so within your population what some of those burning issues are, and you could collaborate with your patient, family, partners, and provider partners to learn kind of where you can focus in terms of designing those vignettes. So think of a vignette as a short paragraph where you highlight the health characteristics, the social characteristics and needs, ethnicity, age, and sex. And so you design a short story, and that becomes a focal point to then have conversations about, okay, in this particular scenario, how could we improve care? How can we start to adjust our models of care to meet the needs of this type of person? And then you can have a variety, 3 to 5 different vignettes to then ground that conversation. And then from there, you think about, okay, so how do we leverage the resources that we have in our OHT? So in the past, when we've brought different care sectors together in a region, they kind of look at each other and go, oh, I didn't know you were providing that service. I didn't know that you provided this at-home visit. So you start to learn together ways that you could leverage the resources you have to then work differently for the particular population or the vignette that you're focusing on. And then, of course, there's this whole level of, when we talk about Black, Indigenous, and people of color, when we're designing these care packages and new models or adapting models, how do we then consider these other factors? What community organizations are working with people that identify as Black, Indigenous, and people of color, so we can make sure that what we're designing is actually thinking of those factors to make it more inclusive. Going to the next slide. So this, the final slide here, is really about the context of engagement. So Ross Baker and Jean-Louis Denis, it was actually 2011 when they started to develop this model called engagement capable environments. So think of your OHT as an engagement capable environment, where you have to think about 3 core components. We want to make sure that in engagement, we are, reaching out broadly to our community and all of its diversity, but preparing people to participate in the co-design. So we'd be reviewing the expectations of patients and care partners, really understanding what are those barriers to engagement, and even doing practical things like pairing existing patient partners with new patient partners to make it more inclusive. So if you're planning a co-design session, you can think about this as almost a checklist of questions that you would ask yourself as you're preparing this. you want to ensure leadership focus and strategic focus. So in your OHT planning, do you think of the leadership model as distributed, where you're continually bringing in patient and caregiver partners to help them guide the process and define the questions that you're looking at in your co-design, and making deliberate efforts to engage with underrepresented communities in a way that works for them? And in terms of staff, ensuring that, assessing people's comfort level with doing co-design. Do they see the value of working with patients and families? Do they know what it looks like to shift power and create an inclusive environment? And getting back to Healthcare Excellence Canada, they've developed a number of tools that could help you assess within your organization or across your OHT how ready people feel to engage and any reservations they might be having. So there's a bit of a culture shift in doing this work to ensure that everyone around the table feels comfortable, that they're able to listen actively, and then learn also how to set boundaries, because we can't do everything that everyone wants, right? So it's about how to engage in that respectful conversation where everyone has a voice, but you're also, moving things along so people feel included, and then you're looping back to check in to make sure it's working okay. So again, think of this as a bit of a checklist for the context around the engagement activity. So I will leave it there and welcome any questions.
Carrie, it's Mike. I have a question. One of the things that I've heard from teams and also QI teams in the past is while they can certainly set the boundaries with patients, what they're looking for is sort of a pre-screener. Patients that understand the healthcare system so they don't have to educate them about it, because what they find is if they bring in patients, they sit quietly and don't speak. Any suggestions?
I think there's pre-work that's required. So depending on who you're bringing into the conversation, it could be, I dare say, a usual suspect, someone who's well-primed in healthcare. You see them at every conference, they're highly involved, and they're not afraid to engage in the discussion. But to bring in these other voices, and I've had experience working with people that were less familiar and not feeling as confident about speaking up during these meetings, it's about meeting with people in advance, but it matters, the person who is meeting with patients and families also matters. So are they able to create an environment where you can explore some of those challenges they might be facing, and also learn what they need to feel comfortable during that engagement? And maybe it turns out that they don't want to be part of a big group discussion with other stakeholders. They would prefer to meet with you one-on-one, provide some insight on whatever you're working on, and then you say, I would bring that to the table. So I think it shouldn't be our goal to bring everyone to the table. We have to see how people want to be involved, give them the tools as much as we can, and then work with them to create what's safe and from their perspective to bring their voice to the table.
Very helpful, thank you. One quick question, because we're coming up close to our time, and I want to hand it back to Rob and Leslie. In BC, they have a group called the Patients' Voices Network, where you can actually draw on a pool of patients. Do we have anything similar in Ontario?
Yeah, so Ontario Health is developing a similar patient pool, and what they've done is they've worked with the PFACs that used to be LHIN-based, and they've pulled in patient and family partners from each of the LHINs to form a new pool in Ontario Health of patient and family partners that, similar to the BC Voices Network, they have opportunities, like say if you're working in a hospital and you want to engage with patients and families, you could contact Ontario Health and say, I really want to work with caregivers that have, on a palliative care project, and then Ontario Health could almost help to match to the patient or family partner, which is what the Voices Network does. What I'd also like to see is Ontario Health and Voices Network having opportunities for patients and families to define the things that they also would like to work on and to shape what that looks like, because it kind of comes from both sides. And I know that the patient family partners at Ontario Health also feed information to CEO and leadership. So they do have a role in, at least having a say in terms of the leadership direction. So there is different ways that patient and family partners are involved, and it's a diverse group, which is really important.
Wonderful. Thanks so much, Carrie. Rob, I'll hand it back to you.
Thank Carrie too. I just wanted to thank Carrie too. I don't know about everybody else on this webinar, but I think we should invite Carrie back for a more full discussion on actually the mechanics and suggestions around actually embedding patients and families into your co-design activities. As you go, as you improve, as you segment, as you collect data, having patient and family perspectives is vital, but it takes some work to how to do that. Make sure that if you have other suggestions for your for future webinars, please let your coach know. And I just wanted to bring up these resources here. This is on our website for all of the material that we talked about today about engaging patients and caregivers. Here's a variety of resources that we have at your disposal. So thank you very much. And we will see you soon at one of our next RISE events. And I think we're having a collaborative coming up fairly shortly. Thank you, everybody. Thank you, Mike. Thank you, Carrie. Thank you, Christina. And thanks, everybody.